Today, we'll look at the role of public health nursing in universal health coverage using system dynamics approach. My name is Lucy. As you've heard, I am a nurse by profession. I'm very proud to be a nurse, despite having enjoyed the advantage of using the broad nursing base to venture into an interesting world, the interesting world of mathematical modeling, health systems engineering. I've also had the opportunity to do a postdoc program at the University of Otago using system dynamics in One Health approach. And I want to believe Rashid yesterday took us. Basically, we've been told over and over again that universal health coverage basically means we should be able to receive good health care without any financial catastrophe. When you look at it critically, universal health coverage is basically saying we need to strengthen the building blocks of healthcare systems, as outlined by WHO. And we also need to note that universal health coverage is not just about finance, it's actually good health. It goes way beyond health systems to encompass other areas of life. Now, health system building blocks have been looked at as what we need to ensure all of us would get good health. WHO actually enlisted a number of them. I hope you can be able to read that. We have service delivery, we have information, we have financing, we have leadership and governance. And the assumption is that if we are able to take care of the needs of those blocks, then we should have an overall goal of good health outcomes. Is that true? Do you think if we are able to cover or to meet the needs of those building blocks, then you're going to have good health for everyone? Yes or no? I need an answer. You know my teacher? Oh, good. Yes, no, we'll see. Now, looking at universal health coverage, we need to appreciate that it's very dynamic in nature. One, even if we were to give you resources to meet the needs of those building blocks of health system, we'll still have different outcomes for different countries. And even within the same country, we are going to have different outcomes at different times. What makes it so unpredictable? Basically because the relationship between those building blocks is non-linear. It is not automatic that if I give you money, then you're going to employ healthcare workers and healthcare workers will provide better health. It is not a given, and we will see why. And the reason is because all those blocks are tightly connected, they are sensitive to change, and once they change, they resort to intended and unintended consequences. Now, the change in healthcare system affects not only the healthcare system alone, but it will expand to agriculture, to transport, to many other sectors. And that is one study which showed that different countries have different outcomes in universal health coverage. Now, back home, the nursing now has a number of actions which have been enumerated on how we should be able to achieve universal health coverage. One of them is action number 6, which states that we need to work alongside other researchers who will systematically collect evidence of impact of nursing on universal health coverage. And I added that, actually, the impact of universal health coverage on nursing too. And we need to be able to identify enablers and barriers, and we need to recommend policy approaches for local, national, and international organizations. Ladies and gentlemen, I want to propose to you that one of such approach could be system dynamics modeling. So what is this system dynamics modeling? It's basically a modern approach. It emerges from industrial engineering. That is why we end up having system dynamics modeling as part of health systems engineering. It's basically a computer-aided approach to policy analysis and design. And we are basically saying there is a characteristic feedback loop of every action you take. Now, real-life experiments are very expensive, and we do not want to take time to give you money and see what will happen. So for us to be able to save money, we do more cost-effective in silico simulation or computer-aided simulation to see what could happen if we took certain actions and what effect of those actions would be, not only to the healthcare system, but also to other systems of the world. Now, what is the epistemology of system dynamics modeling? Basically, we said it's drawn from engineering, mathematics, and modern management. It is drawn from presentationalization. How do you see things at whatever level of healthcare system? And let's see how in a short while, mental models. When you go to the villager, the village man, and you ask them, what is your perception? What do you think universal health coverage is? They should be able to capture what is in their mind on paper and pen. And that is what guides you on how to communicate to them, how to educate them on what universal health coverage is, and how to manage their expectations. Apart from being able to have qualitative bit and quantitative bit, we are able to combine those two and be able to come up with a very comprehensive view. What are the 4 steps involved in system dynamics modeling? 1, the mental model. And the mental models include causal loop diagrams. What will, if I do action A, how will it affect action B, and what will be the result of that action in between there? We'll see that in a diagram in a short while. And then after that, we do something called stock and flow diagram. And that provides a simple common language which is understood from everybody across the divide, from the illiterate to the senior professor, for lack of a better word. And then we are able to capture the stock and flow into computer softwares, and we use differential equations on each of those connections between variables, and then we do virtual simulation and animation. Once we do visual simulation and animation, then we are able to tell behavior over time. You can be able to use numbers. Instead of using numbers for the common person, can be able to show a number of people accumulating and becoming many, for example, in a waiting line of a hospital. Let's just look at it. When you look at that up there, I don't have a pointer, the diagram up just shows there are many variables which are related to one another. And the second diagram shows that we are able to translate those variables into stocks and flows. Stocks are those which accumulate. For example, we have the number of people who are covered by UHC. We have the number of healthcare providers. Those are what accumulate. But we're also asking, what is it that causes them to accumulate? And those are variables. And we show how the variables are linked to the stocks. Anybody can be able to see what are the numbers and what is causing those numbers to accumulate. We have softwares available which we use to do simulation and modeling. Some of them are free online, others you have to buy. We have Vensim, Stellar, I think, AnyLogic, and many others. Now, remember we said each of those relationships must be denoted, must be documented using differential equations. Now, that is just the backdrop of almost every differential equation. Just basically says change in y is dependent on time and factor x. And let me not go to the details of that for the sake of my audience. But if you are interested more in differential diagrams at the end, and any person would be able to understand that. In a nutshell, just to summarize, we say we have a stakeholders engagement where you bring everybody on the table. They do mental diagram of what they perceive system or the system is all about, whether it's healthcare, whether it is immunization, many which have done. And then we put that in a computer software, and then we simulate. Those are the 4 main steps. So why is it that we need to be aware or to adopt system dynamics modeling as nurses? 1, we are able to conceptualize the problem, and we are able to present the problem or the situation back to the stakeholders in a language they understand, in simplicity. If you involve them, because you have to involve them in drawing that model, then they have a lot of ownership of whatever you come up with, and then we have shared understanding from the lowest level to the highest level. Then we have multiple knowledge. Yesterday, on Monday, Prof told us that the people who can be able to actually run UHC are those people who belong to the household. And let me tell you, we do not have monopoly of knowledge. You'll be shocked that those common people in the village are the ones who will be able to tell you what they need to do to make sure that their hospitals are not congested. So never underestimate, whatever from the highest to the lowest level. We have multiple sources of knowledge. And most important, in the pursuit of UHC, we all become equal citizens. No one is more superior than the other. An example of some of the system dynamics project models we've done, we've used it in many public health opportunities. We developed one in cervical cancer vaccination and screening interventions in Kenya. We had our own finding. We need to first focus on secondary vaccination. Then we had one we did in household pollution in Nairobi slums. And you might be surprised that one of the key things we need to do is to make sure that we have environmentally friendly cooking jikos. I know we would imagine we need to clean the environment, but that actually is not the key. Now, system dynamics modeling is able to help us identify key leverage points. When you put that information in a software, you actually torture that information until it confesses something. Something you either knew or something you did not know. Now, looking at our building blocks for WHO, it's a very beautiful model, but we need to ask ourselves, is there something we can do to improve that model? One, we have some missing parts. We have not been able to show the linkage between the building blocks. We also seem to ignore the dynamic nature of health systems, the role of context, among others, and we need to be aware of possibility of that. There is a way how all those building blocks are linked to each other. Let me give you an example, just to follow one of the loops, that if we increase finances, what we expect to happen, and it happens even in a health setting, that because we have finances, then suddenly our drugs are available at the health clinic, isn't it? At the health center. So what happens? The community starts coming more to the health center because there is sudden demand, whether it is real or imaginary. So what happens to the workload of the healthcare worker? It goes higher. What happens to the health information? They need to collect more health information, that is extra workload. When we have extra workload, there is probability of us collecting more data, unfortunately, poor quality data. So it doesn't necessarily mean that an increase in one supply is an advantage to all the others. Now, having tortured that information, allow me to just mention a few things you noted, that as we increase the health information and there is good evidence, I'll just highlight the most important things, or one of the few things. There is a likelihood of having poor quality data and insufficient qualitative data, because more often than not we collect quantitative data. If we increase governance, somehow there is a loop which will show we are likely to have poorly trained new managers, because the ones in the healthcare system have become so well that they are taken up by the private sectors. And then when we increase finances, we may end up with more corrupt practices. And there is actually a pathway which shows that that is likely to happen. And many others. We have poor quality services as we increase the number of patients. Then we have increased utilization of coverage, resulting to poor quality of service, and that is given. Now, why do we need to do PSM in universal health coverage? Just looking at it critically, we've been able to integrate the view of systems through illustrations of internal and mental models by all stakeholders. We can be able to reveal the feedback and potential areas for further exploration. We've been able to complement the traditional data collection approach and analysis, and we are able to make use of available data. Most important, we are able to develop theories and be able to test them. New hypotheses. How much money do we need to give you at a go to ensure that we do not end up overloading the system? We are able to identify different scenarios and be able to do policy decisions And that is all based on the relationship and the holistic view of the system. We build consensus, everybody owns what we come up with, and we can help engage stakeholders to bring together perspectives and data from different disciplines. Now, system dynamics modeling also serves as a foundation for quantitative modeling. Why? Because as we do the qualitative model, remember those causal loop diagrams? It can be able to guide us to know what kind of data we need to collect to be able to populate our model. Is system dynamics relevant to primary health nurses? Yes, it is. Why? We are the first people the patient is in contact with. Is that true? Professor Were talked about first tier, second tier. We have many nurses there. So if we are the first people to be in contact with the community, then we have the responsibility of making everybody know that they are responsible for UHC. How can we be able to do that? We can be able to bring all stakeholders together with common understanding, speaking one language. Remember Prof told us that UHC starts at home, and sure it does start at home. And those are the people who give you an in-depth understanding of the system beyond nursing. Let me tell you, when you have an in-depth understanding of what is happening in the system, you can afford to be the eye in the storm. When everybody else is going below it and wondering what is happening, you know what is happening. Then you do not have to be reactionary, you can actually be proactive. And we are able to work with all other healthcare providers in a team because we know who we are. We don't have to have unhealthy competition. We can be able to have transdisciplinarity and knowing we are not only leading that transdisciplinarity team, but we are also illuminating choices for health, for decision making, and we are also taking part as fellows in policy development. In conclusion, remember, nursing is universal in nature. Nursing is very versatile. I will challenge as many of us as possible to pursue your passion, even if it's not what is conventional to what we think is nursing. The fact that I've gone through systems engineering does not change the fact that I am a nurse, and a very proud one for that matter. And then, nursing is core to UHC. We say without nursing, we will not be able to have universal health coverage, whether in Kenya, whether in developed countries, or wherever we go. And remember, if we are the core of UHC, then we must be strong. That core must be supported, and that core must support. In a nutshell, we are basically saying that nursing is the salt of UHC. It brings flavor and seasons universal health coverage. Thank you.